They have their STEREOTACTIC localization done in the radiology suite, then immediately have the SiteSelect device procedure or a vacuum-assisted procedure done at the same time. It's done with only a local anesthetic, and when they're done, they go home. The whole time between the time they get on the table to the time they're completed and leave the suite is probably an hour to an hour and a half. On the other hand, if you do a needle localization biopsy, the patient comes in the morning, has a mammogram done, has a needle localization wire put in place. They go up to the operating room waiting area. They wait till the operating room becomes available. They undergo surgery using the both local anesthetic and often sedation. They then have to recover from their sedation, and then they go home. So the whole time frame is probably 5 to 6 hours in the hospital.
The STEREOTACTIC guidance gives you that accuracy that you miss up in the operating room. And that's why I turn to SiteSelect, because there are many lesions that aren't amenable to either the core needle biopsy or the vacuum-assisted biopsies. And there are many times where you need a definitive diagnosis, which is the open excisional breast biopsy. And so I use SiteSelect now instead of taking any of my patients to the operating room for a needle localization breast biopsy. I think that should not happen at all, except for a very few cases.
We see the large cores replacing needle localization. Many times you have calcifications in a lobular distribution. You can be fairly suspicious that they likely are ductal carcinoma in situ, or that they are associated with atypical hyperplasia. In those patients, if you just did a needle biopsy, they still have to come back and have another procedure done. If you use the SiteSelect on those patients, then you've removed a biopsy step. The patient only has one procedure, and it's comprehensive. They can get all the calcifications out. You've taken a step out of the progression of biopsies the patient has to go through. One of the really neat things we haven't talked about yet is the fact that the mammograms look better after a SiteSelect resection as compared to lumpectomy. With lumpectomy, there's quite often a lot of skin scarring, a lot of retraction, a large area of increased density that makes the mammogram look very worrisome to the radiologist. Well, you have a lot less distortion of the tissue with the SiteSelect system than you do with a needle localization and lumpectomy.
The difference between having a large tissue specimen versus multiple small cores is you have an idea of the architecture of the tumor, you have an idea of margins. I think this clearly gives a surgeon as well as the pathologist something better to give you a definitive diagnosis.
With this technology, you don't have that. You have the breast in compression for the entire procedure, which I think actually has many advantages. You've fixed the breast and you've fixed the lesion. Then you target the lesion and you very precisely excise it. So you can do so much more a precise excision with this technology than you can with a needle loc, because there's no, well, where is the wire? Where's the abnormality in relation to the wire? You're looking at a mammogram. You're in the operating room with a non-compressed breast. All of that goes away.
One of the disadvantages of vacuum-assisted breast biopsy versus the SiteSelect procedure is that you're taking the tissue out piecemeal. This somewhat limits your pathology. One of the things that I look for in the pathologic specimen is the size of the lesion. When I take the specimen out with the SiteSelect, it is coming out in its entirety, therefore our pathologist can measure the size. Also, I would like to know if the specimen is, or if the lesion is contained within our specimen, and the pathologist can determine margins using the SiteSelect biopsy specimen. None of this is available when we use the vacuum-assisted technique.
In my experience, the core biopsies for calcifications tend to be non-diagnostic a fair proportion of the time. They tend to show either atypical hyperplasia or non-correlative pathology, again in that 10–20% range. So I will tend to take patients with calcifications visible on stereotactic imaging and use the SiteSelect device for those patients. On the other hand, if the patient has a mammographic lesion, such as a solid area or a asymmetric density, the chances of that being cancer are fairly slim, and I'll tend to send the patient for a core biopsy for that, with the expectation that it'll come back benign and I'll be done with it, and that we'll get a correlative pathology result.
My indications for using SiteSelect are all indeterminate calcifications. Any abnormality that I think is suspicious for an invasive carcinoma, because if I don't get a margin with the SiteSelect, I still have a minimal lumpectomy cavity. I don't have to take a huge amount of tissue to re-excise that small biopsy site. And my other indication for using SiteSelect is excising an incisional biopsy cavity that shows atypia.
I generally prefer to use the larger core device for the main reason that I think we achieve a better biopsy, a more accurate overall potential biopsy, especially if there's a greater question of malignancy versus a benign lesion. I think we eliminate completely the possibility of histologic upgrading with the large core devices as opposed to the smaller core devices.
I wanted to learn stereotactic breast biopsy like any other new technology in medicine. How can I do something better? With stereotactic breast biopsy, when you're able to image a lesion that's non-palpable and remove it in a small way, it's beneficial to the patient as well as the surgeon. How long would the average surgeon take to learn stereotactic breast biopsy? Well, attending courses that I would say is an easy 2-day course to understand the physics of stereotactic breast biopsy and imaging, and then hands-on procedures. I mean, clearly you can learn in a 3-day course, 2-day course, and then feel comfortable after about a month's worth of work, maybe 2 or 3 cases a week, being proctored on your initial 3 cases by surgeons that know how to do the procedure.
This procedure is much easier to do than a needle localization biopsy. Essentially, you are looking at the image with the radiologist as the needle is going into that area. You're seeing exactly where it's localized and making sure it's localizing appropriately. And your device is going in guided by the radiologist and by the measurements on the machine exactly to the right area. You take out one piece of tissue the size of your thumb, and for all practical purposes, you always get the lesion out with one shot, with minimal tissue.
For a surgeon to become involved with stereotactic and one who wants to incorporate it into his or her practice, I think it's certainly beneficial to attend one of the established stereotactic courses. The American College of Surgeons has such a course, and then I think it's always appropriate to certainly be proctored for a fixed number of cases and have support and backup while you do your first 3 to 5 cases to make sure that your comfort level is appropriate with the procedure.
I would have much advice for surgeons that are interested in learning the stereotactic technique, because I think it is an essential component of a surgical practice, especially if you have a large breast practice, or even if you don't. But if you're taking care of breast cancer patients, or you're taking care of any significant number of breast disease, patients with breast disease, I think it is imperative that you grasp this technology.
I think if I were to pass on one key technique to a surgeon just starting out, and that's to be liberal, at least on the large core devices, to be liberal with their anesthetic and infiltrate around your inner localization needle circumferentially. Don't hesitate to use at least 20 cc's of local, and if you do this, the patient should experience absolutely no pain whatsoever. 95 to 98% of patients, if appropriate local is used, will experience very little discomfort with this procedure.